in the interest of time, so we can have some questions and stuff at the end. Thank you all for coming. It's nice to see such a great turnout. I'm Emmy Betts. I'm in the Department of Emergency Medicine. I'm also core faculty with Piper, which is the keeper of the list. We have regular seminar series in injury and violence. So this is one of them, and co-hosted by Emergency Medicine. Please help yourself to coffee and snacks in the back. So we're very lucky today to have Ed Boudreaux with us all the way from UMass. He said he's been enjoying the snow because it's pretty warm out there, I think.
Yeah.
Still, right? So he's a health psychologist, probably the national leader in behavioral mental health interventions in emergency settings. And was the PI for ED-Safe 1, which I think he's going to talk about today, and then for the next phase of improving care of emergency patients who are suicidal. And I'll leave it at that because I could go on for a long time. But thank you so much for coming. And this is being recorded for later use, so if people are interested in the link, we'll send it out.
Thanks, Emmy. So I'm really, really happy to be here. The main reason why I'm here was to perform a site review for the ED-Safe 2, which is the grant that we received after the grant that I'm going to review with you today as part of the talk. And as part of that, I met with a whole bunch of people, and I'm really, really impressed with your site and with the resources you have, with the energy from the social liaisons that we met with, who are doing a lot of the clinical care with suicidal patients, all the way to the senior administration and to the performance improvement teams. I mean, you really have a lot going on here, and I'm really excited to have Colorado continue to be a site in our projects. It's one of the sites that I don't have to worry about, which is great. I know that once we get moving, I can pretty much say, hey, just check in with us every now and then, and it has its sort of on autopilot, and I know it's going to get done, and I'm not going to have to worry about it. It's nice to have some sites like that. We have 8 sites as part of the ED-Safe, and we've got about 2 or 3 sites that are like that. Some in the middle and some who I'm having to talk to and browbeat and do all kinds of work with just to kind of keep them moving along. So I'm happy to be here. And Emmy had asked me to give a talk, and what I want to talk about. Well, it seemed like a natural fit to talk about the first study, of which Colorado was a real instrumental site, one of the original 8 sites. So I'm going to I have a lot to present, so I apologize if I speak fast. But what I'm trying to do is compress 6 years of a UO1 across 8 sites into roughly 45 minutes to allow for some discussion. So I'm going to go through things quickly, and I do want to have discussion, but if you can maybe write down your questions and ask it at the end, I think it'll facilitate getting through the material. Because what I want to do is actually present the design, which is going to be of a lot of interest, I think, to people who are doing research in this area or doing any kind of implementation science research. We're going to talk about the screening results, because we had 2 aims, and then I'm also going to talk to you about the intervention. The results of the intervention has only been presented in one other place, and that's the International Association for Suicide Research about a month ago in New York City. So this is one of the only venues that will be receiving the initial analyses related to our intervention effects. So I really want to have time to be able to get to that. I have no disclosures. The objectives, as I just mentioned, are to really understand some of the key components of brief universal suicide risk screening, understand the key components of our intervention, which was a centralized telephone advising intervention called CLASPED ED, and to understand the screening outcomes and the intervention outcomes of our trial. So I'm going to start this with an interesting case vignette. Tom is a 66-year-old male who presents with a foot wound. He stepped on a nail while gardening the previous day. He's got type 2 diabetes, hypertension, and a host of other medical problems, including depression. He presented with no overt distress. He was alert and fully oriented. He denied tobacco, alcohol, and drugs, and he was discharged home and killed himself the next day. So the question that we're trying to answer with the ED-Safe study is, could Tom's death have been prevented? So could we have prevented him from going home and killing himself? And I present the clinical vignette in order to set the kind of context for the study and the type of things that we were trying to answer with our study. As you probably already are aware, the ED visits for self-harm are massive and growing. In 2008, there were 500,000 ED visits related to intentional self-harm. And This is those that we recognize. These are people who actually had a diagnostic code that was related to suicidal self-injury. So this is really just the tip of the iceberg, because what we do know from actually many studies that have gone out and systematically screened patients using suicide risk screeners, including the work that Dr. Allen and I did together in the Psychiatric Emergency Research Collaboration here in Denver. We know that it's just the tip of the iceberg, because when you actually ask people systematically, you find out that anywhere from 10 to 12% of emergency department patients will say yes to either, in the past 2 weeks, I have thought about killing myself, or yes, at some point in my life, I have tried to kill myself. So if you look at those two risk factors for suicide, and you ask all the patients in the ED, anywhere from 10 to 12% will say yes to one of those questions. And that's the medical patients. That's not the psych patients. So the other aspects of the studies that we've done is we've actually kind of isolated the medical patients who aren't presenting with a psychiatric complaint and asked them. So there's this huge reservoir of suicide risk that's in the ED that's being unrecognized. NIMH recognized that, and we knew that this was the case, and that's why the ED Safe RFA was released. So if you want to try to do something about this and recognize that there's this suicide risk, how are you going to detect it and what are you going to do about it, you can immediately anticipate that there are some clinical challenges. And if I asked the emergency physicians in the room or emergency nurses in the room what are the clinical challenges, probably immediately they would be, well, we operate 24/7. We've got to see all these patients. They're coming in through the ED at all times, and we can't disrupt flow. We're too busy to do screening. We don't really know how to handle a positive screen. I mean, how are we going to do any kind of risk assessment or stratification after a positive screen? And really don't like these patients. Let's be honest. These are psych patients, and not many of us really want to work with these psych patients because we feel like they abuse the emergency department. Plus, even if we do want to, what are we going to do with them? We don't have any treatment options for them. We can't treat them here in the ED. They get discharged. There's no outpatient resources, so why even ask the question if we can't do anything about it? There's limited aftercare and referral to specialty services, which culminates in something that I've called Pandora's box. So if you ask about it, you've got to do something about it. And so you let loose all of these evils with asking the question that you can't possibly do anything about. So let's not even ask the question because we don't want to have to deal with the positives. And these were the clinical challenges that we faced in the field. And all 8 sites, regardless of the fact that they sign up for the program, all had these same objections when we first approached them. So I think I set the stage here for those who are not emergency physicians to really fully appreciate the clinical realities of trying to screen for suicide risk in the ED and why it usually isn't done. But also to set the stage for the fact that all of the sites that we worked with who were ultimately successful had these same challenges. So we addressed all of these challenges successfully as part of our project. There are some research challenges, too, that you can ask about trying to understand how systematic screening can be implemented. So this is a systems-based study. This means that you have to try to change the system, how clinicians work within the system on a routine basis. It's not for some isolated research question where you're going to put in a bunch of researchers in there and they're going to ask the questions themselves. Those are relatively easy studies because we have control over those research personnel. How are you going to change the system? How are you going to change the clinicians who are there working at 2 a.m. in the morning and there's nobody really there to oversee or to encourage or to prompt them to do what you want them to do? So and how do you study those? And how do you study screening and intervention in the same study? It's never been done before. So studying screening for suicide risk and implementing a new intervention had never been done in one study before this study. But the RFA that NIMH released said you have to do it that way. We want it separate. We don't want one intervention that rolls it all together. We want to know the effects of screening on suicidal behavior, and we want to know the effects of screening plus an intervention. And the reason they did that is because there's all this literature out there and other disorders like depression and tobacco and alcohol that said that screening alone is not enough, but it could have been enough with suicide because it's a special kind of thing. If you have a positive suicide screen, clinicians know that you can't just discharge that patient without doing anything. If you have a positive tobacco screen, a positive depression screen, or a positive alcohol screen, those people get discharged all the time with nothing being done. But suicide is different. So it could be possible that if you just implemented screening the system that's already in place to handle positive screens could have been kicked in, and you could be preventing a whole lot of suicide without having to do any new intervention. And that could have been quite possible. So that's why we had to separate out screening and intervention. But it was a real challenge from a methodological point of view. So we also needed to design the screening and intervention procedures that could be feasibly integrated into the standard ED care. So we wanted it to be systems-based. It had to be feasible, but it had to be powerful enough to maintain its potency on the outcomes. It's easy to get people to do some sort of hand-waving around this issue and say, yes, we did change something, and it fit into our practice and we were able to do it. But if it's so watered down, it has no impact on your outcomes, then who cares? So we had to try to balance the feasibility with the potency of the intervention. We had to use a study design that could be successfully implemented in busy EDs, 8 of them across the country. And we had to avoid introducing bias by studying suicide while at the same time protecting participants. So if you enroll a person who is suicidal, now just kind of think about this. Most trials and most studies screen out all the suicidal patients, even the depression trials, which is bizarre, right? So you're going to do a study on an antidepressant. If the person is acutely suicidal, they're not enrolled in those studies because they're so difficult and so risky to manage in a trial. Now put yourself in our shoes. All of the patients we enrolled in our trial were suicidal. So, of course, NIMH was very concerned about this. They didn't want to make they didn't want our study to make the wrong headlines. The wrong headlines being NIMH funded trial identifies suicidal patients who go out and kill themselves with no intervention, provided. So they didn't want that to happen. So when we do our follow-up assessments, we had to put in place a system that assessed suicide, and if they were positive, acted on it, even in the control condition, which isn't supposed to get an intervention. So if you call people 5 times and they're suicidal every time and you have to implement your safety rescue plan, that means they just got 5 interventions that they wouldn't have gotten if they weren't part of the trial. So we had to balance out the human subject protections with the study, which is a really big challenge. So here's how we did it. This is just an overview. I'm not going to go into the details because it would take way too long. But what we did is we used a quasi-experimental clinical trial design. In this kind of systems-based trial, it is impossible to do an individual randomize each patient to the intervention because it was systematic screening, so it wouldn't make any sense. You could potentially randomize in a cluster randomized trial different sites, but you would need a minimum of 40 sites to do this trial, which would have tripled the budget. So it was impossible to do a cluster randomized trial. So instead what we did is a quasi-experimental clinical trial where we had 3 sequential phases of data collection: treatment as usual, collected data on treatment as usual, universal screening. So we introduced universal screening only with no intervention. We said, here, screen, and you decide what to do with those patients. The sites all decided what they were going to do with the patients. And then in the enhanced intervention, we added an intervention to the screening for those people who screened positive. And so these phases happen in sequence, and here's a visual depiction of that. So you can see here, treatment as usual phase. You see the introduction of universal screening at the site. We collect the data for the universal screening phase. Then we introduce the intervention, and that's what the intervention is over there. It's a combination of performance improvement that we introduced in the ED and post-ED counseling, which was really the part that we were focused on most. We realized that to try to do too much in the ED was going to be too difficult for this first study. So the ask for the ED part of the intervention was very modest. And instead what we did is we called patients after the ED visit 9 times after their ED visit over the course of a year, including not just the patient but their significant other, if they allowed us to do so, and provided a mixture of problem-solving therapy, case management, and family systems therapy over the phone to these patients, with the idea that we could provide a safety net for them while they were getting into care and could really help motivate them and help them to problem solve to get into outpatient care. And that, of course, is important for aftercare for patients who are in the ED. And you can see we had 2 different outcomes, our evaluations. We had the screening outcome evaluation to the left. And our primary outcome was, could we increase the rate of screening? And if we did that, did we increase the rate of detection of suicide risk? So there's always a possibility you increase screening and everyone's screening, but you don't detect anything new. And you have the same sort of positive screen rate as you did during treatment as usual. That is certainly possible for a variety of reasons. So we needed to confirm that that when you increase screening, you actually increase detection. You identify new people who you ordinarily wouldn't have identified if you hadn't been doing the screening. And then the intervention and evaluation was the primary outcome was suicidal behavior, defined as suicide or a suicide attempt. So that we had two different composite outcomes. That was one. And then there was an expanded composite outcome that is used that includes not just suicide attempt, but other suicidal behavior, such as an aborted attempt. So the person was going to do it but stopped. An interrupted attempt. So they were going to do it but someone else stopped them. So we had a broader composite outcome too that hadn't ever been examined before, that had been promoted as part of the Columbia Suicide Severity Rating Scale, which is a standardized risk measure that's adopted for all FDA trials now. So every FDA trial that tests a psychotropic or a neuroleptic, some sort of neurologically active drug, has to use the CSSRS at every assessment to detect whether or not there's suicide. So it's a standardized gold standard measure, and it discusses all these different kinds of suicidal behavior, but it had never been used in a clinical trial like ours. So we were also trying to look at how that new composite was affected by our intervention. So I just kind of reviewed this. For sake of speed, I'm going to kind of scroll through those two slides. Just describes a little bit more detail about what the screening, evaluation, and outcomes were. But you'll see the results in a little while. So there are 8 EDs. The requirement for the EDs, as stipulated by the RFA, was that they didn't have a dedicated psychiatric emergency service. If you had a dedicated psych-ER, you're unusual. Most EDs don't have that. So they didn't want those EDs because you could have done all kinds of interesting stuff there that never would have been translated to the average ED. So our EDs actually have a nice range. We have some really large EDs and we have some relatively small EDs. We have 2 EDs that are community-based hospital EDs. Even though they're affiliated with an academic wing, they operate just like most community EDs do. They're not a large academic ED. So we had a nice diversity of the type of EDs that we had that we felt kind of approximated what you might see in the general community, although it probably was still weighted more heavily towards academic medical centers for obvious reasons. This is where we do research. Our goal was to enroll in the clinical trial part where we were looking at the outcomes of about 1,400 adult patients. We wanted to split that between those with attempts, so they were presenting to the ED with attempts, versus those who presented with ideation only. And we wanted to do that because we wanted to try to keep the balance of our 3 phases representative of a mixture of severity. Because one of the potential problems with increasing screening is that you increase screening and identification of people who are of lesser severity. So they're not there with a suicide attempt. And so if you increase your screening, you're more likely to detect people who are not there with an attempt, but who are there with ideation, and it might be a milder form of ideation. So in a non-randomized trial, that's a real threat to the selection of your groups. And so if your treatment as usual phase has all these really serious people because you didn't do screening and now all you're detecting is people who will come in there with a serious psychiatric problem, you introduce universal screening and now you're detecting all these people who have moderate risk. Your final phase, the 3rd phase, could have been comprised of a bunch of patients who didn't look like the patients in your control group. And that's a real risk from a methodological point of view. So we tried to counterbalance that by saying, well, we're gonna try to enroll half with attempts as a rough indicator of severity, and half with ideation only, so that we have a similar composition of our 3 different groups to protect against selection bias.
It wasn't necessarily a current attempt. It was a history of it.
It was a current attempt. It was an attempt either at the visit or within the 2 weeks before the visit. So most of those patients, there were very few people who had an attempt in the 2 weeks before the visit, or 1 week actually, not 2 weeks, but who weren't there for an attempt. So for practical purposes, the attempt group here are people who presented with a suicide attempt. You guys probably, if you worked in the ED during this time, you knew that we had research staff who were embedded in the ED who who were looking at every single chart that came through to document whether screening was being done and what the outcome of that screening was done. And if it's a positive screen, they would go and they would do an additional interview with the patient, an eligibility interview, to see if they were eligible for the clinical trial, and if they were and they consented, they were enrolled in the clinical trial. That was roughly the format. And we have a very illustrious guest in our midst who was actually doing that very thing. Because before she was a successful medical student, she was a research staff on the ED-Safe, enrolling patients into the ED-Safe. So when we did identify a patient who was suicidal and they were enrolled, we did a baseline interview during the ED, the Columbia Suicide Severity Rating Scale, which I just described, and then we did telephone follow-ups for over 12 months after the visit. And the CSSRS was administered at every single one of these 5 time points against our wishes. NIMH's DSMB forced us to do this. So 6, 12, 24, 36, and 52 weeks, they got a reassessment using the CSSRS. What we wanted to do was a lighter touch to keep contact with the patient and not actually administer the full CSSRS except for the 6 and 12 months. But they said, no, you got to do it at every time point because we don't make the headlines, like I said earlier. All of these calls for all 8 sites were done at a centralized call center at UMass. And if they detected a positive suicide, a person who met our threshold, which was actually active ideation right now, or a suicide attempt for which they hadn't received medical attention, that was our criterion. If they met that criterion, or the caller thought that the person was suicidal, had some other kind of sense that the person might have been suicidal, then they patched the person in with a warm, live handoff to the Boys Town National Crisis Line, and they did the clinical work, crisis intervention with the patient on the phone. And we used that as our clinician backup because we couldn't keep a bunch of clinicians on pagers. It just wouldn't have worked. These calls were being made 7 days a week, 10 hours a day. So the Boys Town National Hotline actually performed that clinical backup for us, and they did a wonderful job. And then we also did medical chart and administrative databases reviews, and we also did a search of the National Death Index, the NDI. We'll skip through that. I already presented the phases, but this is what our screener looks like. So it's 3 items. It's a segue question that helps to kind of warm the patient up. It's a depression item. It's the first item on the PHQ-9. The second item is an active ideation item. And the third item is whether or not they've ever attempted to kill themselves, so lifetime attempt. And if they're a positive, then we find out what the most recent attempt was. And a positive screen was defined as, a positive screen is, did they ask the question? So were the active ideation and attempt questions asked by the nurse? So if they were both asked, then we consider that a positive screening, so they actually screened. But then a positive detection was defined as whether they had active ideation or an attempt within the past 6 months. So the threshold for a positive screen or positive detection was basically they screened positive on our screening. So we were looking not only at whether or not the screener was administered, but what the results were. And here is our marvelous time series graph that plots out every site in the 3 different phases. And I want to show, I do this every time I present this slide. You see this guy? Not to unblind the blinded chart here, but this is Colorado. It's not showing up there. Well, you see the one with the big spike? This spike here? So this is the real sort of problems with doing naturalistic clinical trials, is when your site is very enthusiastic about adopting your screeners in anticipation of rolling out Epic. And then they turn it on and no one else knows that they turned it on, and then the nurses see that and they all start screening because it's on. You see that's what happens. And then you realize, oh my God, it's on, turn it off, and you turn it off and you see the screening goes back down. And that's exactly what happened here, which is, I think, a wonderful finding. Is we got very close to universal screening by simply turning on the screener in Epic. And then when we realized that it wasn't supposed to happen, we got the folks here to turn it off, and you can see it drop back down, which was interesting and nice. And then universal screening in that phase, it was turned back on, everyone was trained, and you got their screening as shot back up, and then it continued to improve. But you can see that all of the sites, there's a lot of variability in treatment as usual, and then, the trajectories of the sites were different, but all of them in the long run ended right around greater than 80% of the patients in the ED were being screened by the end of the trial. And this is when you collapse all that to just a kind of a simple bar graph, what you see is the detection rates also increased. So the detection of positive, or the definition of a positive at baseline phase 1 was 2.9%. When we introduced universal screening, it rose to 5.2%, and then with continued work and modification and performance improvement, it actually rose to 5.7%. That means that 5.7% of all the sites, patients were positive for either active ideation or for a suicide attempt. Using this definition, we used a broader definition. We didn't use the 6-month threshold. Actually, for the point of the outcomes, just to keep it broad and simple, it was any suicide attempt documented was considered a positive. And so it came out to be 5.7% at the end of the phase, and you can see it as a pretty massive effect size. It's still small numbers, but you can see it almost doubled the detection rate with the screening. That's the same slide. So this is what the time series plot looks like for detection. So these are the detection rates. What I just showed was the aggregate, and you can see that actually some sites, look at the universal screening phase, one site actually increased their detection rates to anywhere from 8 to 10% of their patient population was screening positive with the universal screening. So there's still a lot of variability, and then it continued to rise in the third phase. So what are the conclusions from that part of the study is, and we used I didn't say this, but I should have. We used a performance improvement approach. So some of you probably know what that means. We can talk about it more later if you don't. We used a very traditional, accepted Institute for Healthcare Improvement performance improvement model. And using that model, it is feasible to dramatically increase suicide risk screening and detection during routine care. Detection still falls short of the estimates, however. Remember I said some of the work that Michael and I have done has shown that it's really about 10 to maybe 15%, but probably 10 to 12% would meet the criterion for the definition that we used, active ideation or a lifetime attempt. So the outcomes that we actually reported on these slides is a pretty broad positive. So even with the almost doubling of the detection rate, we're still under-detecting what's out there. And so that's, of course, what we're doing in ED-SAFE 2, is trying to see if we can continue to improve upon the screening and the detection as one part of our aims, because there's something not quite right. There's something that we're not doing in order to be able to maximize the detection rates. So the frontline screening components that we use, which we thought were important to emphasize, is that there's an introduction to the screening, so the patient knows that they're about to get asked some questions that are potentially sensitive, and they know that that potentially sensitive questions that you're asking them is not because of something that they have done, that this is being done for every patient. So it helps to couch the screening so that it's not perceived by the patient as being strange or out of the reason, out of the practice of what they would expect in an emergency department. There's a segue question. I say that we call it a segue question. It's the depression item. The depression item, the first item, is not actually factored into a positive screen. So the person's positive on depression, but not suicidal ideation or suicide attempt. We don't consider that a positive for the purposes of our study. Now, the site can do whatever they want with that, and many of the sites decided that they would give a depression information sheet to every patient who screened positive. And that was a great idea, but it wasn't really what we were focused on for our study. The reason we included it is because during our group work, we realized that just jumping right into, in the past 2 weeks, if you thought about killing yourself, was a bit abrupt. So the depression item, along with the segue and the introduction, helped to ease the patient in, and we thought that we might be able to get a little bit more honesty from the patients if it wasn't just thrown at them. So that's why we have that depression item in there. It's mostly to segue to active ideation. And then we have the ever attempt and if so when. And we used a 6-month threshold mainly for practical purposes. The emergency clinicians in our group and our advisory panel said, look, we can't, even though we know that the epidemiological literature suggests that if you have a lifetime attempt that risk stays with you for the rest of your life. That even if it was 10 years ago, 15 years ago, you're still at some non-negligible risk of trying to kill yourself again. So that some of the literature suggests that it doesn't really matter if it's a recent attempt or an old attempt, you're still at risk and this should be addressed. And while that may be true, it's probably not going to be addressed in the ED. So we had to compromise on that risk factor and say, well, if it's within the past 6 months, then that probably would be more acceptable to emergency clinicians, and it was. And everyone, I think, recognized that if the person had recently tried to kill themselves, that they were at some sort of increased risk in terms of short-term risk, and that something should be done for that patient. So now what? Well, ED-Safe 2, we are continuing to try to implement process improvement and trying to improve the rigor and the fidelity of the screening. But also, the next question is, well, does that do anything for the patient if you detect their risk? Is it really going to impact their suicide? Well, now I'm going to talk to you about the results from our intervention. So the intervention that we were primarily focused on is the CLASP, or Coping Long-Term with Active Suicide Program, that was created and tested by one of our co-PIs, Van Miller, from Butler Hospital at Brown University. And we took what he had developed, which was actually designed for inpatients, to transition people who had been inpatient psych to outpatient. So it was actually designed initially for those patients, and we modified it for use with emergency department patients because for example, the original class started with a clinical face-to-face interview with the patient that was actually quite lengthy, and then transitioned to the telephone interviews after the inpatient was discharged. Well, obviously we couldn't do that in this study. It would have been too difficult. So we moved all of the clinical encounters with these folks to the telephone. So no clinical encounter actually happened in the ED. So we made some modifications to the class. I said earlier it was 9 phone calls, but actually it was 7 phone calls over 52 weeks. You can see they kind of clustered within the first month. So 1, 2, and 4 weeks after the ED visit is where the first 3 of the 7 calls were clustered. The idea being that that's the most vulnerable time that patient is discharged from the emergency department. Even if you have relatively good access to outpatient mental health care, it's going to probably be a month before you get in, or several weeks before you get in. In many places, you can't get the person in right the next day like you would like. So we wanted to provide a safety net during that very vulnerable period, and up to 4 calls to a significant other. And we really tried to get the patients to allow this. They had to consent, of course, because there's some emerging literature that the more engaged the family is in your intervention, the more likely you are to impact a range of outcomes, including suicidal behavior. So we wanted to try to involve the significant other if we could. It comes from a theoretical perspective rooted in suicidology, where there are 4 generic risk factors: hopelessness, problems with isolation or thwarted belongingness, poor problem-solving skills, and a lack of treatment adherence. Then there's a whole host of individual risk factors. And so the class therapist is approaching their interactions with the patient, mindful of these risk factors and trying to address them as best as they can, and coming up with the individual risk factors that apply to that individual. So tried to tailor the approach to the individual. There are multiple perspectives and strategies that are rooted in some other types of therapies. So if there are any psychologists or mental health professionals, it's a very values-oriented type of interview with the patient that comes from therapeutic strategies like ACT, acceptance and commitment therapy. They're also obviously rooted in family interventions, because that's where the significant other comes through, and problem solving and case management. So the class kind of pulls all of these different traditions, which really in the past haven't been blended. So if you look at research, and there might be a study on ACT and some outcome, or family interventions and some outcome. So what Van really did is try to take the best parts of these that could be applied in a short-term basis and over the phone, and take tools from each of these strategies and blended them into one approach. So this is the kind of the Venn diagram of what the class looks like. All the calls, as I mentioned earlier, were from a centralized site, and these were all PhD clinical psychologists with a very experienced master's level clinician as well. They attempted to call the patient at least 3 times at each scheduled call. So that was a real problem, getting these patients on the phone. We had to build a protocol that was not just going to be one and out, because we just wouldn't have gotten very many people, but wasn't so invasive that it could never be translated. So as opposed to our outcome assessment calls, where we tried 15 times over 10 days with all kinds of other support in between to try to get the outcome calls, right? So in a clinical trial, you have to do that because you don't want attrition. And in a clinical research trial, you can do that because you've got money to pay these people to do it. But in a clinical setting, who's going to call the patient 15 times over the course of 10 days and send 3 missed you letters? They're not going to do it. So we had to try to come up with something that was realistic but didn't rely on what might happen in a clinical setting where they call once and if not there, then they just write them off. So we really said, okay, you're going to, for each of these time assessments, or calls, the intervention calls, you're going to do it at least 3 times. They really stopped at 3 unless there was something like they reached the person and they said, well, just call back later. So they didn't actually engage them. Call back, tomorrow. It'll be a better time. So they may have actually tried more than 3 times, but 3 times was the minimum. And they sent 1 carrying letter. The reason why I call it carrying letter is because there's a whole literature in suicide prevention that even a very brief letter that basically says, we care about you, we're thinking about you, that gets sent to the patient after their ED visit can actually influence suicide outcomes. I know it's hard to believe. I still find that whole literature difficult to believe, but there's at least 2 randomized clinical trials that shows that these carrying letters, without any telephone contact, just the letter, can actually improve some suicide outcomes. So we figured, well, if we can't reach the patient, then at the minimum we could send them the carrying letter, and that might actually influence outcomes independent of whether we reached them or not. That's why we included that carrying letter. And it was very easy and cheap to do. So we ran the trial. Only 60% of the patient got any calls. With that protocol, we were only able to reach about 60% of our patients. So 40% of the patients in the intervention group didn't receive the intervention. This is really important to understand, both from understanding what I'm about to show, which is the outcome results, but also when you're thinking about how would this work in the real world. Well, in the real world, a lot of these patients are just not going to be reached. And in the real world, I know that you already have a crisis intervention call system set up, because I've talked with lots of the personnel here, that actually is a little similar to the idea of class, that the person's discharged and they should get a follow-up call. Well, a lot of those patients you're just not going to reach. So when you're evaluating the outcomes, you have to consider this. It's like randomizing patients to drug, and only 40% of them, or 60% of them actually got the drug. But using intention to treat principles and research design and the way clinical trials have grown and evolved, using intention to treat principles, it doesn't matter if they didn't get the drug. They were assigned to the intervention group. They still need to be analyzed with the intervention group. So they still count. And so what that does is it dilutes your intervention effect because they didn't receive it. So adherence and actually implementing the intervention was difficult. You can see some of the statistics here. There's 7 possible calls. The mean was 4.7. The median was 6. And significant other, 4 possible calls with 3.5 as the mean, and the median was 4. So, all told, if we got a hold of the patient, it was kind of almost binary. If we made 1 call to the patient, we were highly likely to be able to continue to make calls to the patient. If we didn't get a call, then they were just lost. I mentioned earlier, just to remind you, there were 2 outcomes. There was the traditional outcome, the suicide and suicide deaths, suicide attempts and suicide deaths. That was the traditional outcome. That's what's often looked at by suicidologists. And then there was the composite that's comprised of death, suicide attempt, interrupted or aborted attempt, or preparatory act. I mentioned earlier we use intention to treat. So if they were enrolled into that phase or that group, then they were analyzed for that group. We performed survival analyses with Kaplan-Meier method and a log rank test, and a time to event analysis using Cox proportional hazards, including all possible covariates. So this is a complex data set. We wanted to look at it from different angles to make sure that we weren't missing important trends. This is just the unadjusted outcomes. So this is the composite suicide outcome by group. So this is not adjusting for any of the covariates or doing any kind of multivariate. You see that we started at 49%. So this is actually a pretty staggering statistic if you think about what I'm saying here, that of the people in treatment as usual, roughly half of which had an attempt and other half had an ideation, 49% of them had either a suicide attempt, a suicide attempt, interrupted preparatory attempt within the 12 months after the ED visit. So half had a suicide composite after the visit. We were able to reduce that. You can see it's roughly the same for universal screening. We reduced it to 41% in the intervention group. And when you look at the survival curve, you can see that even better. So this is plotted, of course, over the year after the ED visit, and you see that the intervention group has significantly greater chance of being without the expected suicide composite. So these survival curves kind of have to flip it. So these are the percentages. The curve is the percentage of the patients who are enrolled in that condition who didn't have the outcome. You can see that looking at it from this view, you've got a significant effect. And this also controls for all of our multivariate confounders. So remember, this is not a randomized trial, so it's really important to control for all of these confounders that can happen between the different conditions. So when you control for all of those, you see a widening and an increase of the effect size of the intervention because they're obscuring some of the intervention through their bias. So when you start to remove that bias statistically, you see a greater distinction between the intervention group and the other two groups. So what we showed here pretty clearly is that screening alone does not influence suicide outcomes. So you can increase screening, but if you don't do something else, some other intervention other than what you already do, you will not increase your impact on suicide outcomes. So we also looked at the traditional. So we looked at both outcomes. Here's the traditional outcome. We saw roughly the same magnitude of decrease when we looked at just suicide and suicide attempts. You can see this is also a staggering statistic that of the treatment as usual patients, 23% had either a suicide or a suicide attempt, and those suicide attempts were generally those that brought them to that actually led to an ED visit. So these are not just suicide attempts they're doing at home, and it doesn't lead to some sort of medical care. And when you look at the survival curves, you see when you look at this outcome, suicide attempts and deaths, that there is a approaching statistical significance, but it doesn't quite reach our traditional thresholds. But the pattern is similar, where it's really the intervention group that separates out from the other two groups. And when you look at the Cox multivariate models, when you compare treatment as usual versus screening, you don't see any difference in either outcome. But when you look at treatment as usual versus the intervention, you see statistical improvements in both of the outcomes. So this is just a different way to look at it, and it's a forced comparison of just two of the groups using treatment as usual as the control condition. So the conclusions that we can make from this are that universal screening alone does not appear to reduce future suicidal behavior. Adherence to interventions in these settings with these types of patients is difficult. Despite adherence issues, a multifaceted intervention reduced future suicidal behavior. Oh, incidentally, we didn't have the results yet for me to present because the statistician is working on it now. But we're looking at kind of a dose response type of analysis where you look at the number of intervention episodes that the person actually engaged in. So you've got all these zeros, and then you've got 1 through 7. So you've got actually kind of a spread amongst that, which is nice for a dose response kind of analysis. You have some variability. And so we're looking at whether the person actually received the intervention and looking at that compared to alternative groups, because it helps to remove the watering down effect I mentioned earlier about with the 40% who didn't get any call. So that, of course, can only be a post hoc test because that's not intention to treat. But it's also instructive, though, of determining whether or not if the person engages, what's the sort of true impact that you have with that individual patient or that group of patients. It's an important analysis to do. And the preliminary work that I've seen from the statistician is that the effect size almost doubles when you look at the people who have received one or more call. So we're probably, when we publish the trial, we'll have that as a supplemental analysis. Now, let's circle back around. This is the end, nearing the end here to the clinical vignette. So Tom, remember Tom, because we had implemented universal screening here at Colorado, the nurse detected his suicidal ideation. And to the surprise of the staff, Tom had a well-thought-out plan to make his suicide look like an accident so his sister could receive his life insurance. Secondary screening revealed multiple stressors, including a one-year anniversary of his wife's death. So loss is often, particularly in older men, a trigger for suicidal behavior. He was admitted from the ED to a psychiatric facility. He's discharged on antidepressants and connected with primary care and had no further suicidal ideation after this visit. And this is a published case report by Emmy. I use this for all my talks about this because I think it really puts into focus and answers the question that, yes, Tom's death can be prevented. Now, obviously, Tom didn't go and kill himself. Maybe he wouldn't have if he had gotten discharged, if he hadn't gotten all this stuff. But I think you can see the value in this patient. It really embodies what happened. And he didn't even receive the class intervention because he wasn't in that third group. He was actually in a different group. So this is, I think, to put a clinical face on the problem and the work that we're doing here in the ED and continuing to work on trying to improve. This guy's life was saved, as was about 27% more people in our intervention group than our control group. That was a relative risk reduction, was 27% for our intervention. All right, I blazed through it in 50 minutes. I did it. Yes.
Do you have any way to track whether any of these people were homeless, what socioeconomic group, or whether they had insurance at all? No. And do you have any idea if those are the people that were lost to home?
Yeah, it's a very astute question. The answer is yes and no. So as part of the criterion for the clinical trial, the person had to have a stable residence and a stable phone because it's the only way we could reach patients. So in any clinical trial, you have to have those eligibility criterion. Now, it didn't have to be a landline, and it could have been that their stable residence was actually living with someone else, so they didn't have to have their own permanent address where was their home. So we tried to be flexible around this to handle patients who were having really tough social circumstances. But if they weren't in a stable arrangement, then we couldn't enroll them, and it ruled out a lot of patients that we enrolled. However, we do have a lot of socioeconomic data on these patients. So the patients we did enroll, we've got insurance status and a bunch of other socioeconomic factors that we assessed at baseline that we can use to look at, and I forget what the results are. We have looked at that to determine whether that moderated the impact and to determine if that was in and of itself a predictor of suicidal behavior. So we do have a study that's published on predicting suicidal behavior in that treatment as usual from our baseline, and I don't recall, it wasn't one of the socioeconomic factors may have entered or may have been in the univariate analysis, but when we did the multivariable analysis, they didn't end up being significant. It was really much more of the clinical factors. So did they have a prior suicide attempt, the severity of their suicidal ideation, and a few other clinical factors popped as predictors in the final model. But we have just started to look at the socioeconomic and socio-demographic differences, so I'm not quite sure what it is. But the problem is that we eliminated many of the ones that are in the worst shape because they don't have phones, and they don't have stable residences. And we didn't enroll anyone who was incarcerated or under state custody either. Yes?
How many commit suicide that you don't catch in your screen?
So, what's the false negative of the screen?
No one knows the answer.
My goodness, we want to know that answer so badly, but NIMH refused to fund our administrative supplement that would have answered that question because they felt like it wasn't interesting enough. But we tried to get it answered because we didn't follow any patients over time who were negative. Only those who were positive. So we don't know the answer to that question, and it's real thorn in my side ever since. But hopefully someday someone will be able to answer that question. We've got a bunch of other studies that can answer that question that are ongoing, but the ED-Safe can't.
Did you directly measure any of those 4 theoretical reasons that are used to describe what might push people into suicidality, like the hopelessness, or were they being treated but not adhering, or the prevalence on it?
We measured some, but not all. So, as you can imagine, this whole assessment that's happening with the patients is being done by phone, and there's a certain amount of time that you have to be able to talk with a patient by phone before they either hang up or they just decompensate and their answers are rubbish. So we try to keep it as narrow as possible. So we do have indicators like the suicide severity and their ideation. Those things we have very well identified. And that was primarily what we were doing at each of those time points. But we also have patterns of healthcare utilization, and we have some other psychiatric assessments, including hopelessness and some other psychiatric symptoms at 6 and 12 months. So we have some of the indicators there, like hopelessness, not at every time point, but we don't have all of them. So I would like to have asked a thwarted belongingness. It's a big part of the interpersonal theory of suicide, but we just didn't have the bandwidth to do it because we had a limited amount of time. About 20 minutes is what people will give you on the phone when you're asking them these tough questions about suicide, and it's a very trying assessment. So we found that about 15 or 20 minutes is what they would give us. Some people would do longer, but so we only asked some questions at different time points. But we do plan on looking at it. So the answer to your question is we have some mechanisms or some theoretical questions that we plan on analyzing. We just haven't done it yet. Stephen?
Thank you. So my question, and this is such elegant research that it's really hard to worry about it too much. My question is sort of touches on what Ann asked, and that's that we know in emergency departments and the epidemiology and the psychiatry is all in alignment here that there are the large population of patients who make suicide attempts and the population of patients who commit suicide are very different. Mm-hmm. One's much larger than the other, and demographically they're different, psychiatric diagnoses are different, and so a lot of the people that are in a positive screen are not at risk to complete suicide. There's much morbidity there, and many reasons to detect and provide help, but they're not likely to ever end up in a fatal suicide action. And so I just wonder, do you have to always be cognizant of the fact that some of the screens are not for suicide mortality?
Yes,
because
you do.
Depression, even, which was excluded, might be an even stronger risk factor for ultimately killing oneself than a history of 6 months ago or whatever, any number of suicide attempts.
Yes, I agree with you 100%. So there's the tension between the ideal and nothing, and in the middle there's practical. So ideally, you're going to train people to be much more observant. They're going to look at other risk factors that might be sleepers. You're going to train people to be much better at identifying suicide risk that isn't as apparent as saying, yes, I'm thinking about killing myself, right? So that's really what we have identified here, and the only subtle ones are those who say no to that question, but say, yeah, I tried 3 months ago, but I'm not actively suicidal now. Well, that's a patient group that most emergency clinicians would probably not really be that concerned about because they're not actively suicidal now. That we try to enhance in terms of recognizing that those patients are the ones that will go out and kill themselves, even if they're not actively suicidal now.
That's where the positive hopelessness
that's right.
is such a robust.
And that's where recall that the screener we're doing is a first-line screener to try to identify a group of people who then should have additional screening. So what we didn't talk about, because we didn't have the time, is that in in the third phase, the part of the ED part of the study, we tried to get the physicians to do a better job at identifying other risk factors. If they had a positive frontline screener, they were supposed to do a secondary screener to try to help to bucket those patients into those who probably needed to have additional psychiatric evaluation and those who perhaps could have just gone home without a psychiatric evaluation, because you do identify a whole motley group of people along a spectrum. And if you get all of them in your psych eval, you have the risk of clogging the ED and of overwhelming the psych eval services. So there's some real systems consequences to saying everyone who's positive has to get a full psych eval. That I don't think you want to do. So that's why that secondary screening by the physician is so important. It's tiered. You have to have your own physicians make a decision as to whether they're going to feel comfortable discharging this patient because the risk level is not enough for a whole psych eval. There's another option too. You can discharge them, but with just a psych resource consult. So they don't come in and do the full eval, but they're going to come in and perhaps do a safety plan or provide some resources for this patient that the physician doesn't think really needs a full eval, but doesn't feel comfortable discharging them with nothing either. And that's a terrible medical legal risk. If you've identified suicide risk, you're going to discharge them with nothing. I mean, that'll lose every time in court. But if you show that you gave due diligence, thought process, you document your secondary screening, you decide that the person doesn't need a full psych eval, you get a psych PSL resource consult to come in and provide some resources, you covered yourself in true form with the patient, and you've also got a nice medical legal story to tell in the document, in your record. But you know, I think the reason why there's going to be this group of people whom are at risk for suicide, and if you ask them, they won't tell you, but if you ask them, they will tell you. Many of these people are just waiting for someone to ask them. They want to be asked. You can actually do some interviews with patients, and they'll tell you that. I bet you if you talk to Tom, he probably was hoping someone would ask him about this. But then there's going to be the group that are at risk who you ask, and they're going to say no because they want to go out and kill themselves. And I don't know, other than, well, there are people in the world who think that they can solve that problem with the implicit associations test, the IAT. So we have a different conversation about that. That proposes to be kind of a truth discerning instrument that can tell if you have subconscious risk for suicide that you do not express out loud, and that it's better than asking the person. So the jury's still out on that, although Matt Knock got the MacArthur award for it. So there are suicidologists who really think that you can do this. I don't know.
I'm a little surprised that you didn't have substance abuse either in your model of potential causes, nor that it wasn't also addressed as part of the treatment.
It is. Yeah, it's both part of the model of what we look at as in our predictive equations and in our control factors, because it's part of what we control for. It was also part of the counseling. So as part of the class, there was a substance use assessment, and the advisors who were working with the patients worked with them on their substance use and also in trying to get them into substance use treatment. So it was part of it. It just didn't have. There were a whole bunch of other layers in there that I wasn't able to describe, but substance use, alcohol, and illicit drug use were incorporated, and we reassessed those at our outcome measures as well.
Do you have data that suggests an effect of age? Is intervention more effective in younger people than older people?
That's a great question, particularly considering the strength of geriatrics research here. We're working on those, so we haven't looked at all of the moderators in as much detail as we want, but we will get to that. We have at least two investigators, Emmy and another investigator at Rhode Island, that has an interest in looking at age and other factors associated with age. So I think that we have the data to answer the question. We just haven't looked at it yet.
I was wondering if you've collected any qualitative data, particularly around stakeholder perspectives, patients, providers, physicians, even administrative feedback about screening and then the intervention.
It's a great question. For EDSafe 1, we had a considerable amount of qualitative data that was primarily driven from the clinician's perspective. So we had already done a bunch of studies with patients, and there's literature out there that patients have no problem being asked these questions. And just in terms of a practical observation, when we were going out and we were enrolling hundreds or thousands of patients in these screening studies that we've done separate from the EDSafe, people have no problems consenting to the study and answering the questions, and they're like, well, no, whatever. And I've done some cognitive interviews, if you're familiar with that procedure, with suicide questions to find out what question people react to the best and which ones they find offensive. And by and large, most of them don't have any problem. And these are with medical patients and psychiatric patients. So it's not just with the psych patients. Psych patients are used to answering these questions, so there's it doesn't even faze them. And what we've found is really patients don't mind being asked the questions. If there's a trend at all, the trend, as a clinician, what I would prefer to do would be to ask about passive ideation first before I ask about active ideation. So, have you just thought about going to sleep and never waking up, or have you ever thought that you wish you could just be dead? So starting with a passive ideation question is a good segue into that more active ideation question. So as a clinician, when I approach patients, and I'll ask about passive ideation first, because that gives me a bit of a better flavor for what's going on. And then I'll ask about the other risk factors and try to nail it down to whether it's actually active ideation. I think patients react to that just from my point of view and from when we were pilot testing all these different questions. There was a bit of a tendency to accept that question better than, have you thought about killing yourself? And I'll tell you an interesting side anecdote about those questions and about whether clinicians accept them. Clinicians don't like asking about killing. They have a lot less compulsion against asking about hurting. And so when we rolled it out at my site, the screener in the electronic health record said, over the past 2 weeks, have you thought about killing yourself? I go back now after the study's been done for 2 years, and they changed it without me knowing. Now the item in our EHR is, have you thought about hurting yourself? And it's because the nurses didn't want to ask killing. So that was a very demonstrable example. They went through the trouble of actually getting someone to change an EHR. Now that's
I'd rather kill myself.
So I think the killing is a bit of a problem for the clinicians. Unfortunately, that's where all the standardized measures read.
So the PHQ-9 says hurting.
Hurting, yeah, that's right. PHQ-9 says hurting or killing. Actually, it's double-barreled.
So I'm just going to say, I know we're just right after 1, and I'm sure some people have to leave. But we've got you for a little bit longer today, so maybe we can take a few other questions of people who want to stick around. But thank you all for coming. If you want to be on the
Thank you.